Hi, good evening, everyone. Welcome back to our journal club. It's very nice to see you all, and you are spending your time in the evening. It's Friday, supposed to be it's family time, but all of you are committed to the regular meeting with this area in hand surgery. So this evening, we thank to Edu, who are willingly to share the reading and he agreed to read four journal, which is going to be a good information for us to learn from those authors, from those four publications, so that we could discuss it and grab the message. And also, I would like all of you to give your opinion after the readings. Edu, are you okay to start for now?
Yes, yes.
Yeah, good. So it's good also
Okay.
to know that you are not traveling this time. As you mentioned last week, I was afraid that you may not be able to give the reading, but you are here with us now. It's very nice to know that. And I will help you with the screen share as you use your cell phone. It's going to be better for me to help you. All right, now time is yours, Edu.
Okay. Okay. Thank you, doctor. Thank you, senior and colleagues for the opportunity. This evening, I will take to share about journal about management of electric head injury. Next, sir. Next. Yeah. There are four journal. The first is about the review journal about the electrical injury of the hand and upper extremity. The second was the using the uh, prefacial tensor fasciolata as for the electrical burn on the teeth, and the third was the uh, defining the use of the pedicle groin flap and pedicle abdominal flap for in this era, this hand this microsurgical era, and the last was the frequency of the amputation in electric burn injury compared with the non-electrical burn injury. Okay, next. Next. Yes, yes, this is the first journal. It's from the Nashville, Tennessee. It's a review article about medical injury of hand in the upper extremity. Next. Yeah. When the first was electric was introduced to the society, there were first reported electrical injury at uh, 8, 18th century, but and electric injury itself has become more and more frequent. Although it's only around 3% in total compared to all the burn injury. And usually electrical injury is involved with the upper extremity, and in severe case it may cause an amputation. Okay, next. Yes. Uh, as we know that electric injury, we should understand about the Ohm law and Joule law, and the electricity itself in our daily life is usually 60, 60 until 100 hertz. Usually 60, which is in the range of our normal heartbeat. So that's why it can may cause damage or disturb our cardiac rhythm to the frequency itself is to the frequency itself, and it can cause non-let go phenomenon usually in alternating current because the flexor tendon is way much stronger than compared with the extensor tendon. So usually the extremity, the hand can grab and cannot let it go when it's caught by electricity. Next. Yeah. Okay. We know electric injury is can divided by high and low voltage, but there's an interesting about electric injury in a high voltage setting. Electric injury can happen without the person touch the source of the electric. It can happen. It it is the rational bit around behind it is the electric is ionize the air surrounding it and make the area surround it become a conductor to transport the electron. So the electric injury, so the electric can blast can transmit without the person touch the electric. And the greater the run, uh, according to the Ohm law, the Joule law, the greater current, the higher the heat it can produce. Usually, the greatest is when the 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 change between the change from the high conduct high conductivity to the low conductivity. High conductivity is in the nerve, muscle, and the low conductivity is in the tendon, bone. So why usually the most damaged part is on the wrist, since it's the transition between the high conductivity to the low conductivity. So, and the electric injury itself, it will cause a greater mortality up to 60% if it pass through the heart. And the mortality can be as low as 20% if the electricity doesn't pass the heart, usually from leg to the other leg. Okay, next. And the first, when we, what should we do in the initial management consideration? Maybe as per usual, power should be shut off immediately. And when we found unresponsive victim, we can do the ACLS procedure. And if there's other concomitant injury around 50%, we use the ATLS procedure. Next. Yeah. Uh, as like in any other burn injury, fluid management is important. In electric injury, we use a Parkland formula, but sometimes it's really underestimate the 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 total body surface area involved in burn injury. So due to the injury itself, it's happened uh, on the muscle, not only on the skin. So it's wider and larger than we see at the than in the appearance. Uh, in the urine output, we usually use half cc, but if there's a risk of myoglobinuria, we should increase it 1 to 2 cc. Uh, the fortunately myoglobinuria itself is rarely to cause mortality if we can give the fluid management and follow the protocol to reach the urine output 1 until 2 cc per kilogram body weight per hour. It can heal itself. It can repair itself. And also in electric injury, we do ACG monitor. And in the if if there's a sign of compartment syndrome, we should do the fasciotomy. Next. Yeah. Electric injury is it's same compared with the burn injury, other burn injury. There's a three phase, and the initial phase is focused on the resuscitation, stabilization. But the difference in the initial phase in the electrical injury, we should uh, recognize the of injury, which is requiring emergent surgical, such as fasciotomy. Next. Yes. Okay. It's already widely accepted that we should do the compartment. We should do the compartment release in the compartment release in the extremity erectile injury, which we suspect is a compartment syndrome. There's a indication of immediate surgery where whether we found a progressive neurologic dysfunction, vascular compromise, increased compartment pressure around 30 millimeter Hg, and if we found a systemic clinical deterioration. Next. Clinically, surgeon usually use 4C for this review article. Use color, consistency, capacity, lead, continuity. But unfortunately, 72% of surgeon impression is different from histopathologic approach. So it's not so the certain impression is not passive, is good in measuring uh, good in measuring uh, compartment increase pressure. So why in some center they use MRI to see the destruction, the edema of the surrounding tissue. Yes, and the other problem, uh, after we do the release the compartment, we need to cover the resultant defect using healthy tissue. Uh, Important structures such as tendon, bone, nerve, is more optimally treated with the free tissue transfer. Although in electrical injury, success rate of relapse is lower compared than in non-electrical injury cases. And we need to do the splinting to help uh, to to protect the function of the head. Yeah. So the summary is although high voltage electrical injury is rare, it may cause damage or morbidity in the young working class, male usually, and it can a major source of morbidity and mortality. In the initial management should rely on trauma, burn, and life-saving protocol. And if we found a compartment syndrome, if we suspect a compartment syndrome, we should take the patient emergently to the operating room. And the other system organ can also be affected by electrical injury. Next. Yeah, I think that's from the first review article. This from the second article. This article is held in China. They do the anterolateral tight fascia flap for reconstruction in electrical burn injury in hand, in finger. Yes, next. Next. Yeah. At first, electrical injury is the most devastating burn or injury. It may cause important structure in finger, especially to be exposed. It's like a tendon, nerve. So we need to do the early repair and reconstruction at the first time. But in this microsurgical area, they usually do the free flap. But sometimes traditional free flap is too bulky. So that's why they use free vascularized fasciolata flap combined with split thickness skin graft. This method, these uh, cases, they do in 3 years, 2015 until 2017, in patients and held in China. Next. In this surgical technique, they do the debridement and the fasciolata flap harvesting and do the vascular anastomosis. Then they do the skin grafting and the post-operative management. They do elevation, mitigation, and Doppler ultrasound monitoring. They do in the third day due to they use fasciolata, then cover it with the skin graft, and they put a gauze on it, so they cannot monitor it directly. So after 3 days, 3 days after surgery, they take off the gauze and they start to do the monitoring and direct observation also. And since they use skin graft, split thickness skin graft, they also give scar management and they do physiotherapy. Next, this is the result. If we can see, there's 11 patients. There's two complications that happen here. And the first was the partial skin graft loss. Uh, both of them are the partial skin graft loss. But the first is caused by wound infection. Next, this is the next. This is the case. In the picture, we found it that the electrical injury happened on the second and the third finger, and after they do the debridement on the second finger and third finger, they give a fasciolata. It anterolateral type fasciolata, anterolateral type, and they harvest the fascia, only the fascia, not the skin. After that, they wrap the exposed bone tendon using the fasciolata, and they do the anastomosis and the snap box. The important thing there, if in this article they also mentioned that if in electrical burn or burn injury we want to do the free flap, we put the anastomosing the artery vein is uh, not near the injury to avoid to minimize the risk of thrombosis due to the destruction of the vascular. So they do the anastomosis on the anatomical snap and they put a skin graft. Next, yeah, this is discussion. Uh, there, actually, there's a lot of traditional method to close the defect, from the local flap, abdominal flap, reflap. Reflap itself in this journal, they divide there's a traditional free flap and the vascularized fascia flap. Uh, the vascularized fascia flap, there's not only the tensor fascia lata flap, but there's also a lot of vascular fascia flap that can be harvested from the superficial temporal fascia, radial forearm fascia, and this novel technique they use the anterolateral tensor fascia lata flip flaps. Usually the fascia has have advantage. They're a thin, quite similar thin as like a super thin flap, and they can construct the uh, complicated on the complicated defect such as in the Achilles tendon, patellar tendon, or complicated abdominal wall defect. Next, here's the advantage of the anterolateral tensor fascia lata flap is has the satisfactory appearance, low donor side morbidity since it's only the fascia that we harvest.
Edu?
They is uh, they they need a gauze they need a gauze or pressure dressing to fix the skin graft. So that's why monitoring of the is not possible at the first time. And the was the post-operative observation of the circulation of the facial flap is difficult. Next. Yes. Uh, in in conclusion, we found that we say that fascia lata is broad and vascularized tissues that serve as an ideal substitute for soft tissue is quite satisfactory in function and appearance. We have a low donor site morbidity and may and fascia flap might serve as an attractive option to cover electricity damaged finger. Since in finger it's better to put a something thin to cover it than a bulky tissue. Okay, this the West is the next journal. This is the defining indication in pedicle groin flap and abdominal flap uh, in reconstruction in this microsurgical area. Okay, next. Yes. Pedicle flap, groin and abdominal is a workhorse in 90, 70, and 90, 80. But right now is widely usually do the free flap to do the reconstruction in hand and forearm reconstruction. Due to the pedicle flap, they have a disadvantage. There's a lot of disadvantage from the need of flap division, patient discomfort, maybe increased hospital stay, and etc. Next, yes. Uh, okay, this is the anatomy itself. There's four flap basically. There's a green flap is based from the superficial circumflex iliac artery, as we can see here. And the second is the superficial external pudendal artery. And the third is superficial inferior epigastric artery. And the last is paraumbilical perforator. Yes. Okay, next. Okay, there's a general principle in using the abdominal flap and pedicle groin flap in reconstruction of hand and forearm. There's we do the breathing first, and bring the hand to the abdomen or the groin and design the flap, and we do the insetting, and we need to do immobilize, and the last is we can do the division. Okay, usually uh, turn back. So, yeah. Okay. Usually in dorsal defect is best are best covered with the inferiorly based flap, whereas when and the volar defect are best covered with the superiorly based flap. If we found double defect on the dorsal and volar, we can use a bilobe flap, inferiorly based flap, including two artery. Uh, One is from the groin, superficial circumflex iliac artery, and is from the abdomen, a superficial iliac inferior epigastric artery. The superficial in the groin we can to cover the dorsal side, and the polar side we can cover with the superficial inferior epigastric artery. Okay, next. Here the first case, the indication of this of pedicle flap of pedicle abdominal flap in hand and forearm reconstruction. Usually, if according to the journal, they say in children age less than 2 years. I know it's a little bit hard to understand to put children less than 2 years in this position, but uh, they they also say that in children less than 2 years, the diameter of the vascular is smaller, and the second was the risk of the vasospasm. Next. Yes. The second indication, if to coverage distal stump in preparation to do the to hand transfer. So we cover the defect first, and after that, in the second stage, after we divide the flap, we perform to hand transfer. Next. This is the case. They put the groin to cover it, then they perform the to hand transfer. Next. Yes. And for the high volt high voltage electrical burn, if we found the hand itself is survived only by the collateral circulation, we cannot found the recipient vessel to support our free flap, so we can use the abdominal or pedicle groin flap. Next. This is the case when we found unsalvageable the soft tissue of the thumb. So after we do the burn, the bone itself is still not yet necrotic. We can put groin flap to cover it to make the bone still viable, and we can do the division of the flap after that. Next. This is the case for in the mutilating hand injury. Next. This is when we found a multiple digital amputation. Uh, if we can, we can do the pedicle abdominal or groin flap to give the to maximize the length of the finger, since that's the main principle in reconstructing hand defect. Next, yeah, this if we found a multiple defect in the finger, hand, and forearm, we can use it separately. Every defect on the finger, we can cover it all at once. Next. Yeah, this is the same, but the difference is we cover all the defect using one pedicle flap. We syndactylize it, and after that we divide it, and after we divide it, we desyndactylize it, so the finger can be separated. Yeah. So in this current microsurgical area, free flap coverage should still be considered, but pedicle abdominal flap still have a place. It's quite relative. For example, in the case that I mentioned earlier, in children less than 2 years, usually the vessel is small. There's a risk of vasospasm. Sometimes for a beginner plastic and reconstructive surgeon is quite difficult to do the free flap. But for the free flap consultant or person who usually do the free flap even in this pediatric patient, it's still doable. So it's a relative indication. So and the last is the in the war zone or in the disaster zone with the limited resources, abdominal flap or groin flap, it can be considered. Since it's quite simple and it can give a good result. Next, yeah. This is the fourth journal. Is about the amputation in electrical burn. Next, yeah. Okay. Electrical burn is around 5% compared to another burn. So it's not many, but it's quite causing high morbidity and mortality. So in this electrical burn, we usually find the neurologic symptom, hip muscle involvement, damage to the hip muscle. We found the compartment syndrome, and in the severe case, we may found the non-viable extremity. So the amputation are often required to reduce overall morbidity and enable the survival of the patient. Next, the method is electric burn, were matched regarding the sex, age, and percent total body surface area, and third degree burn to the control group based on the closest responsivity score. So amputation itself is divided into minor amputation and major amputation. Minor amputation such as when we amputate a finger or in the distal tip of the finger, and major amputation if we do amputation at the level of wrist or ankle, maybe. Okay, this is the result. They found that there are 105 patients, 35 patients of electrical injury, and 70 patients of non-electrical injury. The difference is they found a difference in the presence of inhalation injury. There's a higher inhalation injury in non-electrical burn, and the length of the hospital stay they found higher in the non-electrical injury. This may be caused by amputation from electrical injury. Next. Yeah. This is the parameter. The major amputation is 27 times, 27 cases in electrical injury compared 22 cases non-electrical injury. The difference usually in electrical injury, they perform amputation at the early stage after they do treatment and they observe at the first time they found it is uh, not selfish, so they do the amputation. So that's why if we found here the time from birth amputation in electrical injury is shorter compared to the non-electrical injury. Is shorter. And also in minor amputation is also shorter in electrical injury. And the thought surgery is shorter in electrical injury. This because they perform amputation at early compared to the non-electrical injury. In non-electrical injury, they do the treatment, the clean the wound, and after the extremity or finger or it's not self-visible, they do the amputation. It's different in electrical injury group. They do the treatment, they observe phase, they observe, and after they found it is not viable, they do amputation at the early stage. So that's why the amputation in electrical injury is done early, and the total uh, length of stay in electrical injury is shorter compared with the non-electrical injury. Okay, next. In conclusion, electrical injury may cause a massive and deep tissue damage, which make a major and often minor amputation necessary more often. And usually, they do the major amputation is performed for non-function for functional reason due to non-viable tissue. Next.
All right, that's it. You want to add some more information, Edu?
No, that's enough.
Thank you very much. So, colleagues, we have joined the 4 readings by Edu, and it's quite nice to know that it's kind of like a review for us to know the pathophysiology, to understand back the understanding about the electric burn injury. And so with some of concern with the amputations at the last part, in which we understand that by amputations, it makes a lot of difference with the other type of burn injury, which are non-electrical caused. And it seems like that the electrical burn injury gave quite good data, although the readings was not presenting about the functional outcome, which we understand by amputation, what do you expect? So the other 2 in between, we discuss about the potential reconstructive choices for fingers, where the authors provided us with the examples of using free flap by taking only fascia lata tissue, which is quite good to understand that the main advantage of that particular tissue with free flap transfer could be recognized. And the last point from the readings, we joined the discussions as a review about the use of groin and abdominal flap, which is still an armamentarium that might be good for surgeons, reconstructive surgeons, or whoever surgeons deals with problems with electrical burn injury and need to reconstruct any defects in hand and particularly in the distal part of the upper extremity. Okay, now let's discuss our readings. Wants to share opinions or ask questions. So please, you are welcome to turn on your camera so that we could represent the real physical meeting where we could meet each other. All right, so let me just start with the burning questions. Edu, it looks that Edu moved from the camera. Maybe he needed to do something. Hi, Lina, how are you? Yeah, you are still muted. Let me just unmute you. Okay, now you can. Yeah, we
Okay.
can.
Well, for me, the pedicle groin and abdominal flap I haven't seen and done it for a long time, but I think it's a good choice if you don't do any microsurgery. My question is, if you based on the SCIA, then I will consider the pedicle groin is an axial flap. Is it correct?
Yep.
Yeah.
That's true.
But if you see the cases that they present in those articles, mainly is a random flap. Am I right? Because in a multiple finger, they
Yeah.
make a small flap. Is it a random one? Dr.
Okay, let
Teddy?
me invite Edu to respond to the question.
Yes.
So it's a random flap.
Yes.
If you put
Yes.
it in
Yes.
the multiple finger. So,
Yes.
but
It's a
I'm a
random.
little, okay. So if a random flap, then do we have to keep the proportion between the width of the flap to the length? Because in the article they write keep the base flap narrow and adequate length. I thought if you use it as a random flap, then usually the proportion between the width and the length should be taking account.
One.
How
Yeah.
can we design it? That is the first question. And the second question, if random flap, as we do, like, let's say we do in abdominoplasty, we know there is a layer of fascia scarpa and the other one, the deep fascia. So if we prelevate the abdominal flap, how thick should we take this subcutaneous? Is it enough if we including the fascia scarpa or really until the deep fascia? I think that's my question. Thank you.
Well, thank you very much, Lina. Okay, let me invite you to respond to Dr. Lina's questions.
Yes. Okay. About the random flap, they didn't they didn't uh, uh, explain about the thickness of the flap and the dimension and the ratio length to width ratio. But I think uh, it's it's not until one one and one compared to two, satu banding dua, it is around one and one and a half. So at that can be increase that can increase the successful rate, and this maybe they can do the elevation of the flap until the fascia, all of the soft tissue, all of the subcutaneous tissue is elevated and put it in as a flap. So usually the flap is quite bulky.
Thank you. What do you think, Dr. Teddy? Can you give
What about,
some
yeah.
suggestion about that?
Yeah, before I give my own opinion, what about the level of the thickness? Although the journal, I mean, the Cotton brothers did not mention about how thick is the, or what's the level of the flap harvesting. What's your opinion, Dr. Edu? Maybe you read it somewhere in the journal?
No, the journal doesn't explain it, but I think elevating the flap until the dysphasia is more safer.
Yeah, okay. My comment about that particular journal, the title does not really reflect what the contents tells us, because they give the title that in this current microsurgical era, where the groin and abdominal flap should be modified with better understanding about perforator vessels, about angiosome, and even with perforasome, they could make it better in terms of discussing the topics. But we did not see that from the presentations that those two, I mean, those authors, the two Katan's brothers did not really mention anything about the advancement of microsurgery with perforators, angiosome, and perforasome concept in their works with abdominal and groin flaps. In fact, they started with the scheme or the drawing about perforators, about blood vessel, but they did not really point what's the importance of those blood vessels. So that's why Dr. Lina questioned you and questions us whether the flaps that they presented were pedicle flap, sorry, random flap rather than axial flap. To my best understanding, we need to bring the advancement of understanding in the flap science, applied science about flap, to understand that no flaps is now random flap. So all flaps should have its perforators. And I could just randomly pick the example of the picture from the readings. If you understand, this does not take a principles of length to width ratio, which we conventionally understand about random flap. If you see the base of the flap, it's much smaller compared to the length of the flap, where the flap is really cover the whole, radial side at that dorsal part of the hand, where the pedicle might not be really that wide. So it means that the flap should be axial flap. It does not follow the old teaching about random flap. That's my first comment. So this means also that the concept with this vessel could be elaborated in the discussions. Unfortunately, we did not see that the authors really discuss the importance of those perforators, those blood vessels in the conventional or traditional abdominal and groin flap. And including also some multiple flaps that they harvest and cover it for multiple fingers like this. There's no such, old teaching about random flap. All flap has its perforators. But then when we follow the definitions of axial flap, that every axial flap has or bears name of perforators, then we need to go into more detail on what perforators. From this picture, we do not really know which part of the abdomen, whether they put the hands in the periumbilical area or it's truly in the groin area, we do not know, because there is no explanations about that. If we look into the legend here, it's said that it's abdominal flaps,
Abdominal flaps.
meaning that flaps is considered as different or standalone flap in terms of each flap vascularizations. That's quite confusing. So that's why I was questioning the title of the readings, where, bearing the term here in the current microsurgery era, they did not really point what's important of their publications or their readings. And the reading is actually quite new in 2016, where microsurgery has been quite long years. So then the last question that Dr. Lina pointed out is about the level of the flap harvesting. I believe when you do really believe that you are taking perforators, then you could rely on the scarpe fascia or even thinner. I got a chance in the past that I know an example of case, massive, huge burn involving the hand and also almost all of the forearm. Chinese group put the upper extremity in the abdomen, and they took only very thin abdominal flap, which we would not be daring enough. We do not dare enough to harvest such a huge flap in the abdomen by taking only very thin tissue. So I did not get the chance to contact the authors because we suspect that what they harvested was actually full thickness skin graft, but we did not get the answer. But if we believe that they really harvested flap, it should be with perforators. So some perforators were included in their very thin flap. So meaning that we are not thought that we can go back only to the old teaching about harvesting the very thick groin or abdominal tissue, which include the deep fascia. So my note is, when you are really certain about perforators in your flap, you do not need to go too thick with your flap. You can go as thin as carpe fascia. Lina, back to you if you have further comment on that.
Yeah, let's see. They shown one picture with the all on the dorsum of the hand, dorsum of the fingers, the four fingers, and they draw four flaps, two from the lateral side and two from the periumbilical. I'm suspecting that the two from the lateral side is a random one, because if you see the cross of the SCIA or the SEPA, it doesn't show. Yeah, I mean the other one.
This
Number
one?
34, slide number 34.
34. This one?
No, that is figure 10. Figure 10. Yeah. I think the lateral one could be random, and the periumbilical could be a perforator, because there is a perforator surrounding the periumbilical. Or maybe all random then.
Yeah.
I don't know. And the other question of me is, if you put the flap as one, as a syndactyly, usually you divide the flap 3 weeks. And the second step, when is a good timing to divide the syndactyly? Is it another 3 weeks or 6 weeks? Or how do you decide that?
Yeah, that's important questions. Edu, did you get the answer from the reading, or you have your own opinion?
That is in figure 11, I think, the case they showed, they put it as one in the syndactyly. but it didn't tell us when to separate the syndactyly.
They give explanation when to be syndactylize it. There's no explanation in the journal, but usually maybe we can do the general rule. We do division in the third week, and and we can, for the safety, maybe we can do the separation not all at once, but uh, one finger first, and to observe the viability of the flap.
Yeah, this is very interesting. Let me invite the others. Friends, any one of you who would like to give opinion about the timing of the second stage, or maybe like Edu mentioned, he may also have the third stage because he divided the fingers twice. I mean, in two stages, not twice, in two stages. Any opinions or ideas? Lina, if it is in your own practice, what would you do?
I will syndactylize that in maybe 6 weeks. Do you think it's enough time to wait after the separating the flap? So we separate the flap in 3 weeks, and then the second operation is another 6 weeks.
All right. So I may not agree with you because, yeah, Edu, please.
Yeah, I think it's safer if we do the separation in stage, not all at once.
Half. All right. So I think you are just okay if you divide the flaps in the next 3 weeks after the first divisions from the abdomen. Yeah, just 3 weeks. And I believe in 3 weeks, you have distributed, you would have distributed vascularizations in each finger so that you could go into one stage on dividing the 3 fingers separated to each other. I do not think that we would need to go for more time to divide the second stage. I mean, only one finger from the other 2, and then the last one would be the last 2 syndactylized digit would be separated. Just in one time, after 3 weeks, you could divide it. It's going to be just safe, because at the first stage, you allow separations and all the flaps lift from the 3 fingers, not from only one finger, right?
Okay.
Yeah, that means that the next 3 weeks, it has already been settled down on its own area in every fingers, on every digit. So it's going to be just safe.
Okay. So Dr. Teddy, you suggest the second divided syndactyly, you just need to wait 3 weeks, and you can do directly to all 3 fingers, right? Okay.
Yeah.
Thank you.
I assume I may also do it earlier rather than 3 weeks. I can do it in 2 weeks because for the first 3 weeks, those flaps already been in part of independence of its vascularizations on the 3 digit as its bed, right?
Okay.
Yeah.
But
So
do you
if you are
dare?
afraid,
Do you dare when you divided the syndactyly fingers, dividing and also debulking in the same time? Do you dare to do that, Dr. Teddy, or you will do the debulking in another 3 months? Or?
yeah, that's a good question. So I believe that should be an important point in the writings by the authors. We cannot, go back into the previous era where we cover the hands with bulky tissue. In this current microsurgery era, if you do not do microsurgery, you go into your workhorse with that groin abdominal PUP flaps, you have to cover the hands with thin flap. So you do not need to go for further thinning of the flaps. So in the case that you are not able to provide the hands with thin flap, yeah, I have to wait. I would not dare enough to thin the flap when the time comes for flap division. So I need to settle the flap enough for another, you don't really have the strict timing.
Yeah.
You can just be relaxed for 6 or 2 months or even longer.
Okay. Okay, thank you.
Oh, thank you very much. That's very important question that you raise up.
Yeah, because I find a case and I find it difficult. It's a simple flat, but
Yeah.
to put somebody in 3 weeks, and if you're not succeed, then yeah,
Right.
that's a
Good
problem.
point. Yeah,
Yeah,
thank you.
thank you.
You bring up the old flaps into, fruitful discussion. All right. So any other, please, colleagues? Or Dr. Edu, do you have your own questions after reading those 4 journals?
I think it's already answered by you, Dr. Eddie, about the thinning of the flap. So usually the problem if we do the abdominal or groin flap, I do full thickness with a lot of subcutaneous tissue. I think, is it possible if we do the thinning at the first time, Doc? Maybe we reduce the subcutaneous tissue not until to the fascia, but only just half of the subcutaneous tissue. Is it possible?
Yeah, that's good. You are actually bringing the discussion into the current understanding about perforators. So once you could identify perforator in your flap, you are welcome. You have the freedom to thin your flap at the very beginning. And even you do not need to discard any tissue. When you are first, you start it with.
Katanya dinernya kurang.
So starting from the very beginning, you heard first thin flap. If you are afraid, based on our own study in Jakarta, if you could identify the 2 layer of the fat tissue, so you just rely on the first layer, superficial layer. Dr. Lina mentioned the level of scarpe fascia would be just safe. What you can do if you are not the one who have the skills in using ultrasound, you can invite colleagues from radiology to support you, to assist you with identification of perforator. Make sure that you rely on certain area of the tissue in the groin, in the abdomen, or the periumbilical area. Ask them to identify the perforators. It's fantastic. And then when you know where the perforator is, then give your design, elaborating your flap by relying on that perforator so you can harvest the flap thin enough. You do not need to take all the thickness of the abdomen, which is, it's not the current practice, too bulky for, and even for dorsum of fingers and hand. It's not ideal. You're not going to be like, current plastic surgeon. So don't be too shy to invite colleagues from radiology who are good in using Doppler ultrasound if you are not taking a chance yet by mastering the skills with ultrasound. They're going to be happy to be with you, either pre-operatively or intraoperatively with you in the OR if they are happy with you. But then the system in the hospital might need to give facilitation so that they don't come to OR without taking credit or without taking advantage with their fee, be it in the public hospital or in the private clinics or private hospital, so that they would be very happy to support us, support your work. So my questions taken from the first reading. How would you explain that the current of the electricity might not passing the heart you bring us a statement that is good to know that the current comes from one lower extremity and just move out to the contralateral without passing cranially. Edu.
Yes, yes. They give a statement. Uh, there's 20% of mortality, only 20% mortality compared to 60 mortality if the electricity is passed from the right hand to the left hand. But if the electricity pass on the right leg to the left leg, there's only 20%. Actually, we cannot uh, make a conclusion that the if 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 the electricity only pass from the right leg to the left leg, it will not pass to the heart. It's still there's still a possibility the electricity is passed through the heart. So, but I think it's based on their own statistic. Maybe the distance is quite far. I don't know, but they give a statement like that.
Okay, maybe it depends also on the the voltage of the electric current. I'm not quite sure because I haven't reading deeply into that pathophysiology. Anyone in the audience could help us? Because both of us were not sure with that explanations. All right. What about the fascia, the free flap taken from the anterolateral, the tensor fascia lata in the anterolateral thigh, which I believe also rely on the perforators. But then you have to be sure that you are first quite long pedicle or blood vessels so that you could anastomose the vessels quite proximal in the snuff box area if you are dealing with the finger area, which is quite long. I predict your pedicle should be more than 10 centimeters to avoid tension.
Around 10 centimeters.
Yeah, and it's going to be good to have a sizable diameter of vessels so that you are safe with that, small free flaps, but having quite long pedicle. Any idea or questions? The drawbacks that the flap is covered by skin graft and so on. You're going to deal with a scar and also potential contracture because of that skin graft. That's quite debatable. You put fascia, but you need to cover it with skin graft. Fascia may prevent contracture, but then the skin graft,
And we have a difficulty to, and we have a difficulty to observe the viability of the fascia. Since we cannot see it from the outside. We only see if the graft is alive, then the fascia is alive also.
Yeah, definitely, definitely. No comment from the audience? Anyone, please? Okay, so I would like to invite any of you in the audience. We thank this evening that Edu have read the 4 journal for us.
I have a question, sir. Maybe
Yes,
can we do the adipophyseal flap instead of free anterolateral tensor fascia flap, sir? Adipophyseal flap from the dorsum of the hand of the manus. So
right, but but you need to make sure that your fat tissue is not thick. If you rely on perforator flap, then you do not need to take fat tissue. What's the importance to provide fat tissue? If fascia is thin enough and could provide good platform for tendons to glide. I do not think that, adipofascial flap would be better than fascial flap, because the fascia is considered thin enough already and provide good platform for any tendons to glide. In the past, people may take the adipofascial flap from the radial forearm, or some people may take it from the ulnar forearm, because they might be thin enough in low IMT. Sorry, what? BMI, sorry, not IMT, BMI. With people with low BMI might have quite thin adipofascial tissue in their forearm, but you do not need to do microsurgery. But for fingers, of course, you need to provide microsurgery. You cannot rely on that, tissue from forearm to cover the fingers, like the example in the journal where it involved also the distal interphalangeal area. Okay, so what we haven't discussed through the readings is about the complexity of the system in the fingers, in the thumb, and so with the hand itself. That would include problems in the wrist. Dr. Edu has mentioned that the transition area to have the conductivity of the tissue bearing to provide isolator or conductor for the electrical current is the wrist area. So wrist area may also prone to electrical burn injury. And I believe all of you have observed the disaster in the wrist area. So the complexity to bring the patients back into function, although it's not perfect in function, is still an issue that we haven't discussed through the readings that we got this evening. It's very complex. So I would like to invite any of you in the audience, if you are interested reading journals for more complex problem for fingers, for hands, and for wrists, not only discussing tissue coverage, but also how to create better functional outcome, rather than only happy with, fancy and heroic free flaps for whatever free flaps that you do, but the hands, the fingers, the wrist does not function well. So plastic surgeon has to elevate themselves with more functional outcome working in the hand area. So any of you are welcome. If you are too shy enough to, volunteer yourself now, you can contact me personally and we would together find the journal, respective journal that may have the good discussions to provide better functional outcome, following up with the topics that Dr. Edu has picked up for this evening, which is very nice to refresh all of us with the understanding about pathophysiology of electrical hand burn injury, and so with the reconstructive technique, and so with the additional information about amputations. All right, if there is no one who would like to say something, then we may end this session. Let's join me. Give big applause to Dr. Thomas Edu. Thank you very much, Edu.
You're welcome, Doc.
Yeah, see you all next week and have a nice evening.
Yes, thank you.
Goodbye.
Thank you, Dr. Edu. Thank you, Dr. Teddy. Bye.
Thank you, Doc.
Goodbye.